Well, good afternoon, everybody. Let's try that again. Good afternoon, everybody. Oh, that's great. Wow, what a wonderful turnout. This is just fantastic. For those of you I've not had the pleasure of meeting yet, I'm David Goff, Dean of the Colorado School of Public Health, and it's really my great privilege to introduce Dr. Tim Byers for his last official lecture at the Colorado School of Public Health. I hope it's only his last official lecture because I hope we'll be able to get him back to interact with our students as years go by. This is a wonderful turnout, and I asked him if he knew why everybody was here. He said it was for the cookies, and I said I didn't think we had any cookies, but I think it's really because of the love that you all feel and we all feel for Tim. Let me tell you a little bit about Tim. He told me to keep this short, and I said, well, I am short, but I wasn't going to keep this short. How often has Tim listened and taken direction from other people? So I didn't think I needed to take direction from Tim. So Tim received his medical degree from the from Indiana University, and he earned his Master of Public Health during preventive medicine residency training at the University of Michigan. He's been a truly outstanding faculty member here at the School of Public Health and the School of Medicine for over 2 decades, and we owe a large debt of gratitude to Dick Hammond, who recruited him here. Tim's worked seamlessly across the spectrum of clinical research and public health research. His research focus has been largely in the area of cancer prevention and improving community health, with his work on nutrition, obesity, tobacco, and cancer screening. He has over 360 publications in the peer-reviewed literature. That's a fantastic legacy, including many in our best journals like the American Journal of Public Health, American Journal of Epidemiology, and so forth. And a lot of his work has really informed public health practice and clinical practice in the real world. So for those of you who may not know much about our school, we have a Center for Public Health Practice. Our center has the primary responsibility for training the public health workforce in Colorado. It was assigned this responsibility by the state back in 2009 in the state's Public Health Improvement Plan. And Tim, as our founding Associate Dean for Public Health Practice, was also the founding director of the Center for Public Health Practice and led it until very recently. He brought in HRSA grants to help fund training the workforce in the state and the region. Most recently established the Rocky Mountain Public Health Training Center to focus on Region 8 for Health and Human Services, one of only 10 centers like this in the nation. He's also been the founding director of ECHO Colorado, a bidirectional learning health system program here on the Anschutz Medical Campus. In addition to these roles in the school, Tim served as deputy director for our Comprehensive Cancer Center for 5 years and associate director for cancer prevention and control for many years. And as the founding chair of the Colorado Cancer Coalition, he molded this first of its kind partnership in the nation to focus on cancer control. Tim's received many honors, too many for me to list from here today because I did say I'd be short. But I did want to mention the St. George Award for Service from the American Cancer Society, and one that I suspect he holds very highly, the Mentoring Award from the Latino Research and Policy Center here at CU. Just last month, Tim was awarded the Academic Public Health Practice Excellence Award from the Association of Schools and Programs in Public Health. It was wonderful to see Tim honored for that, with that award for his excellence in academic public health practice and his role as a champion for strong state and local public health workforce. Finally, Tim was selected and will receive the 2016 Joseph Addison Sewell Award at commencement this year. The Sewell Award is named for the first president of the University of Colorado, and this award is given only to individuals who have made exceptional contributions of leadership and vision to the Anschutz Medical Campus. And, you know, this recognition couldn't be more appropriate than it is being given to Tim. So I think I can speak for everyone here today when I say it's been both an honor and mostly a pleasure to have Tim as a colleague.
I'm about to cut you off.
Mostly a pleasure. So I do want to mention that I'd like you to all join us for an informal gathering at Cedar Creek after the lecture. We've let them know there might be a bit of a crowd. And then please join me in welcoming Tim to the stage for his last lecture.
Well, there is a slide behind me, but there's really only 2 slides in this talk. I'd forgotten, actually, I need somebody to help me out here, maybe 2 people, because I have a little handout that I forgot to distribute ahead of time. Got me clamped with all these old friends coming in. Just pass those out if you would. So the handout is it's kind of like the program that you get at a junior high concert. Thank God I have a program. I know when this is going to be over. So it's going to walk you through my talk. What you'll get, it looks like this. A little introduction. David already put us 5 minutes behind. I'm going to talk a little bit about my life, professional life, before I started focusing on prevention. And then the topic of my comments is really different kinds of reflections on prevention, per se. And Lori Crane accused me of having a Debbie Downer title. No, I don't think prevention is a problem, but there are problems with doing prevention, and I'm going to reflect on those. Then we'll have a little period of discussion just about the problems, just about what I say about prevention. Then I'll give you a little picture about what I think I'm going to do for the rest of my life, and then there will be a broader discussion about anything you want, the meaning of life. We have a pastor here with us. Anything you want. So that's it. Now I opted for no slides because I think the best talks I've ever given are talks where I did not use slides, because I feel like I can communicate better that way. But as you know, it's harder to do. So I did do just a little bit of preparation. I sat on the fence since about, when was it, January or February, when I first mentioned to you and Olivia that I might want to do a last lecture. And I said, well, I'm not really sure. And so you put it on your weekly reminder thing. And so once a week I'd get a reminder from Jen. Are you sure yet? Are you sure yet? And so thank you for that. And I think in retrospect I was on the fence for too long, mostly because I felt a pressure to make this my best lecture. And I decided it's not going to be my best lecture. And so that helped. In fact, when I was throwing away my books over the last few weeks, I ran across this one. And this is a little publication that came out of a workshop that I was part of in D.C. on cancer prevention back in 2003. And I looked at my comments, and I'd forgotten that they had transcribed the workshop. And I was one of the directors of this, and so I had some introductory comments. And I was curious to go back and see, well, what did I actually say? Because I remember I didn't have slides, and I just spoke from the heart. And I'll say that was my best lecture. So that takes the pressure off. I mean, if you're interested in reading what my 10-minute best lecture was, I'll scan it and we can put it online wherever this is posted. And if time allows, I might actually do a reading or two from it. We'll see. So who was I before prevention? So after medical school, I joined did some training. I joined the Indian Health Service for a couple of years on a reservation in Nevada doing general medicine. Moved up to Tacoma, Washington for 3 years, working first with the Puyallup tribe, setting up an urban clinic there, and then with an HMO in Tacoma. And I first started really thinking about prevention as a problem when I was in practice in that HMO. It was called Sound Health. It was the first federally funded HMO. In fact, I have the dubious honor, I think, of being both the first physician in the first tribally funded clinic with federal money, the Puyallup Indian Clinic, and the first federally funded HMO. Now, Sound Health was much like Kaiser, much like Group Health, and it had very much a middle class, and I'll say heavy on the worried well population. And so as a physician, people were coming to me with Prevention Magazine articles. Now, how many of you know Prevention Magazine? I wasn't sure it was still in print, so I looked it up just a short while ago. Yeah, it's still in print. And they're still putting stuff out, like in the recent edition, the 10 top things you can do to prevent cancer. And I looked at them quickly. What I know are the top 2 things weren't on the list. And I'm pretty sure one of the 10 is wrong. So that's Prevention Magazine. So patients would come to me with articles. And they'd say, well, what about this? You know, what about the all-nut diet? Or what about this, that, and the other thing? And I said, well, I'll look at it and see and let you know. And so I would look at it, and I couldn't figure it out. There was just not enough basis to understand it from there. It sounds like the mic is going dead, but let me know if you have trouble hearing. So Prevention Magazine was the first problem in prevention that actually led me into the field of prevention. Well, how did that lead me into the field? Well, it's because I decided I wanted to get some more training, and it was either going to be emergency medicine or preventive medicine. And because I really loved emergency medicine, I like procedures, I like the idea of doing something fast, getting it over with, and moving to the next patient. And but I opted for preventive medicine anyhow, knowing that there's a lot of questions that came out of Prevention Magazine, that came out of my patients, that I really was unable to answer. So my intent was to do a residency in preventive medicine back in Ann Arbor at the University of Michigan, which I did, and then go back into clinical practice. About halfway through that residency, I got a question from my then 4-year-old son that came at the right time because I was just tilting towards maybe not going into clinical practice. He was at the time going to a school every day, preschool thing. And he knew that I was also going to school. Getting my MPH, my preventive medicine residency. And so I would have the habit of asking him every day, what did he learn? And so one day he asked me, well, what do you learn? And I didn't feel like describing epidemiology and biostatistics to him. So I said, what I learned is I learned how people can stay well. I thought, well, that's a good answer. And he said, how? So, well, we eat good food. Don't ever smoke tobacco. Eat good food. Get good amount of rest every night. And that's how you'll stay well. He said, what else? I said, well, that's about all we really know for sure. And he said, but you go to school every day. So that's when I decided to go into research. So I did go into research. So number 1 on my list of problems, as you can see on your handout, is Prevention Magazine. Number 2 is prevention can be political. I'm going to bring this book up again. This was a workshop that we held at the Institute of Medicine just a few months after releasing a report by the same title, Fulfilling the Potential of Cancer Prevention and Early Detection. This was like 2003, 2004. And I edited this report on behalf of the National Cancer Policy Board, which is part of the Institute of Medicine. And so we had this workshop, and it was kind of a first up for the Institute of Medicine, because usually they just release their reports and then they think the world has changed. And we sort of convinced them, no, let's have a little workshop and bring people back together shortly after we release the report and get their reactions to it. And so we had the director of the NCI and various people there talking about this. I bring this up as a political example because the report almost did not get released. Our number 1 recommendation, as we wrote this report, we had, I think, 10 or 12 recommendations. Our number 1 recommendation was that Congress should give the Food and Drug Administration, the FDA, the authority to regulate the manufacture, marketing, and sale of tobacco products. And the director of the Institute of Medicine, who is a scientist, understood the political ramifications of that. You're nodding. You know what, you know. And he came back and he said, you have not conducted a formal policy analysis. This conclusion isn't supported scientifically. And we can't let that pass. We said, really? Yeah. So we thought about it for a while, then we went back and we rewrote the number one recommendation. And we said, Congress should give some federal agency the authority to regulate the safety of tobacco products as manufactured, or something like that. Went through the same political review, came back, no, not good enough. And then we came back with a third recommendation, and we just talked about marketing to children. That Congress should give some federal agency the ability to protect children from tobacco marketing. And even that didn't pass. So if you read, so we got to that point, and I said we got to reconvene our policy board and talk about this. So we did. The policy board talked about it. And on the table was the possibility that we were going to just trash the whole report and not publish it after all that work and after it was ready to go. The policy board decided not to do that. So instead, what you'll see, if you ever look at this report, and it's pretty dated now, what you'll see is a recommendation on tobacco, which literally, if you read it, doesn't say anything. but all the evidence is there in the report about it. So my problem number 2 on the list is prevention can be political, and it's often political. I think the problem with tobacco now is clear as we look politically around the country. The rate of tobacco use is twice as high in Kentucky as it is in California. It's actually twice as high as it is here in Colorado as well. Twice as high. And the risk of dying from lung cancer is twice as high in Kentucky as it is in California. I think the interstate variation that we now have in preventable causes of death, like tobacco use, is a shame for our country. And it's time to actually federalize things like tobacco control in the United States. Now, I just wrote a review that'll come out in a month or so on what's happened in the last 25 years in cancer death rates in the United States. They've declined by 26% in the last 25 years. Remarkable progress on many things, such as lung cancer, breast cancer, prostate and colon cancer. And in the commentary, I said the same thing. We should I use the word federalize this. And so when this, of course I have co-authors, they have different ideas. And so when this went through the sort of their political thinking as co-authors, they encouraged me to get rid of the word federalize and say that we should do something like have a more coherent national policy or something like that. So prevention is political, and I think those of us who are professionals need to be more engaged, not less engaged. And there's a new opportunity with the new tobacco tax coming here in Colorado this year to get heavily engaged in, I think, worthwhile political fights. My next problem is prevention is a shadow. What do I mean by that? Well, we don't have in our community, we don't have professionally, those of us who practice prevention, we don't have notches on our belt that indicate how many specific lives we've saved. Maybe we should do that. Every time we think we've saved 1,000 lives, we should put a notch in our belt. We don't do that professionally. And in our communities, there are not marching survivors of disease X who are advocating for awareness and money and policy change and all the kinds of things. So in prevention, it's a shadow. So many of us in the room are probably alive now, and we would not be alive if it weren't for prevention. Vaccines, seat belts, the fact that many of us chose not to use tobacco or IV drugs, or many aspects of prevention. Yet you don't see it. And so I think one of the skills that we need to develop better as a profession in public health is the skill to talk about and communicate about what's in the shadows, about the 1,000 lives per day or the 1,000 deaths per day in the United States that are not now happening, that otherwise would have been happening had we not done what we did a generation ago for cancer prevention. And I think, especially if we talk about preventable fraction, population attributable risk, things like that, rather than rates and relative risks, I think we'll be better off in terms of communicating. But that's a problem. It's a problem I haven't particularly solved, but I think we need to be aware of it as we paint better pictures. The next problem is prevention is not 100%. Doesn't always work. Doesn't it piss you off when somebody says they have a 92-year-old grandfather who smokes 3 packs a day and he's perfectly fine? Yeah, it kind of pisses me off too. Or when somebody has a 32-year-old niece who just got colon cancer, but she's a vegetarian and she jogs and she's fit, and doesn't that piss you off too? Yes, it does. The fact is that prevention is not 100%, and so we can't say that this vaccine is necessarily going to prevent. Well, for some vaccines we can actually say it's pretty darn near 100%. But for most of the big cards, tobacco, obesity, physical activity, healthy diet, even seatbelts, we can't say it's 100%. And so that becomes a communication problem when we talk to our patients or our friends or the general public, because we can't guarantee absolute prevention. Everything then comes down to risk. And the perception about risk and the way we talk about risk is a fuzzy, abstract thing. I think we as professionals have trouble with it, and I know the public does as well, this perception of risk. So epidemiology is sort of the science of understanding risk. There's 3 definitions that I like to talk about. One is, the standard one is the study of the distribution and determinants of health and disease. That's kind of boring. The one I like better is epidemiology is the study of people broken down by age and sex. Or even better, I think it's the study of suffering with the tears wiped away. And I was reminded of that recently. I spent 10 days in Lyon, France, a couple weeks ago, and working for the WHO, doing a consultation there. And part of the work there featured making these enormous tables of evidence. And so, you know, I'd be putting in thousands of people. We had some of these tables were pages and pages long, putting in studies with thousands of people, thousands of deaths. And I turned to a woman next to me once in a meeting when we were talking about this, and I said something like, doesn't it really get to you sometimes when you think about all the suffering that's behind these, you know, 14,281 pancreatic cancers that we just wrote into this table? She said, yeah, every now and then it does. So actually my favorite definition of epidemiology is that. It's a study of suffering with the tears wiped away. But we got to remember that those tears are there and that there's individuals behind it. So I'm going to do a little reading from this. I think I've got time. And if I can find it. Yeah, and so my introductory comments to this workshop were on the number of 60,000. So 60,000 was a number of lives per year that we very conservatively estimated could be fairly easily saved if we would make certain changes. Now, we're not talking about eliminating tobacco and so forth, because there we're talking about hundreds of thousands of lives. But just a few minor changes, 60,000 lives. So my comments were about how do we think about 60,000 lives? And so I boiled it down to one. And right in the middle of my talk, I said this. I took a walk last night when I got here. This was in D.C. I was walking by the White House, and I remembered when I was first in Washington in 1971, which is when the National Cancer Act was being signed and when the tobacco epidemic began to turn down. But those events were not at all prominent in my mind in 1971 because I was a student participating in one of the Vietnam War protests. At that time, I was walking by the same spot I was walking by last night, the gates in front of the White House. And I was carrying a sign on my chest with the name of a boy from Kentucky who had died in Vietnam. I was carrying a candle and yelling out that name when I walked by the White House. Just as I was remembering that moment last night, I looked down, and on that very spot there was a rosebud So I picked it up and I walked with it for a while. And then I was moved to go over to the Vietnam Memorial. And I looked up randomly in the book there under Kentucky. And the first name I saw had 3 names. A first, a middle, and a last. And of those 3 names, one of them was mine, and one of them was that of one of my children. I went to that spot in row 66, panel 9E, and I found the name and laid the rows. So anyhow, I was reflecting on what does an individual mean? What does an individual life mean? Recently, I was at between innings of a Rockies game, watching it on TV. And I went to the kitchen, and I grabbed 3 Oreos and a glass of milk. And then I said, do I really need these Oreos? That brings me to the next problem. Free choice. Free choice is a problem in prevention. Whether you're going to buckle your seatbelt or eat Oreos or do anything else or get a vaccine, it involves choice. So it's not just a matter of us scientifically determining that something is likely to be effective for prevention. We actually have to think about and work in this realm of choice and when it comes to both policy, making the healthy choice the right choice, as well as health education and basic communication. The problem is that there's future discounting, even for us old guys. The Oreos tasted really good. Yes, I did eat them. Future discounting. It's especially a challenge for young people when we're trying to avoid diseases in the 7th and 8th decade of life. The next problem is prevention is a bother. Sometimes it can be not something we'd rather do at the moment, thank you, programmatically. When I was at CDC, I was there for 6 years, and it took me about 4 years to figure out what the game was with year-end money. So the problem for us on the outside is we can't get the money. The problem on the inside is you can't spend the money. And so we never knew until halfway through the year what our budget was going to be. I think it's worse now. And so oftentimes in the summer, as we approached the October 1, we would project we're going to have year-end money unspent. So we needed to look for channels, easy ways to dump money. And so it took me about 4 years to figure out that that was the time when your new ideas could be launched. And in fact, things like the behavioral risk factor surveillance system were launched with year-end money initially. So that was the time to be creative. And so they came out with a call in I think it was either my last or second to last year at CDC for year-end money ideas. And so I talked with people in my branch, and we put out this idea. We said, okay, well, we know that women coming through the breast and cervical cancer screening program are loaded with other chronic disease risk factors. Overweight, hypertension poorly controlled, undiagnosed diabetes, using tobacco, physically sedentary. And isn't it irresponsible for CDC to only tell them your breasts are all right, come back next year, when they know that there's other problems? And so I made a pitch to the cancer division so I was in the nutrition division, a whole different silo at CDC, made a pitch to the cancer division, essentially that pitch. And they said, they thought about it for a little while, and then they got back and they said, no, essentially it's going to be too much of a bother. Prevention's a bother. What do you mean a bother? Well, we're focused on making our programs work and getting women in for their mammograms and their pap smears. And if we start thinking about other risk factors, it's going to sort of bog us down and we may not keep our numbers up. I said, thank you. We went off in our division and we proposed it anyhow. We proposed a program that would be a bother for them, and it got funded, and it's called Wise Woman. There's now a Wise Woman program in most states, and I'm glad we did it. So yeah, David, sometimes you do have to not take no for an answer and push ahead. Holly, where's Holly? There you are. So I remember one time you and I were talking. We had just done 2 small randomized controlled trials proving that if you ask people in Medicare to get a colonoscopy, they'll get it. About 5 or 10%, depending on how you send the brochure, whether you follow up with a phone call or not. But between 5 and 10% of Medicare beneficiaries this is back 10 or 12 years ago, maybe 15 years ago, would actually get a colonoscopy if you would just urge it to do it. And so we had just done 2 trials, and I don't know if you remember this conversation. We were in my office talking about what's the 3rd trial we should do, because we had some leftover money. We had $50,000 left or whatever. And we said, maybe it's the wrong question. Maybe it's not what trial should we do next. Maybe it's what can we do for $50,000 to get people into colonoscopy. So we shifted our whole way of thinking, and we started doing mass mailings. The last reading I'm going to get here was another excerpt from my talk, and it goes like this. I got a letter last week from a woman in Colorado that reminded me about the value of single lives. We're doing a mass mailing campaign in Colorado. This dates it, 2003. We're doing a mass mailing campaign in Colorado to Medicare beneficiaries to ask them to ask their physicians to give colon cancer screening, which is now a Medicare benefit. We have tested this out, and we know we can get a 5 to 10% bump in the screening rate. We're doing mass mailings to the entire state. So that's what we decided to do. We said, how much does it cost? How many people are in Medicare? We could afford it. We just do mass mailings to the entire state. We did it in waves so we could evaluate it. After we did 35,000 mailings, I got a bunch of letters. One that I got back last week was from a woman who said that the letter had come too late, that her husband had died of colon cancer after being seen for years by his physician for management of hypertension. In fact, he had even had vascular surgery. Unfortunately, during all this time, no one had told him to get screened. It's not a surprising story to me. It happens all the time. We can reduce colon cancer death rates substantially in this country if we simply apply what we know. But most poignant to me was her comment at the close of the letter. We went to the moon in 1969, and you're telling me that we still have to be sending letters to people to do this now? It's 2016. We still need that. So prevention can be a bother, but it's nice when prevention works. And Holly has led this Colorado colorectal screening program that I think has saved by now about 400 people from having colon cancer. Because they've had their polyps identified and removed. So it's great when it works, but sometimes it doesn't, which is my next problem. Sometimes prevention doesn't work. Just about exactly a year ago, I was driving through the rain in a rental car in Philadelphia, trying to get to the AACR annual meeting where I was supposed to give a couple talks. One of the talks was on the point of we as health professionals need to be more engaged in political discussions nationally around nutritional supplements. Because we've done a lot of supplement trials now, and one thing we've proved for 4 different supplements is that you can actually increase cancer risk by taking super nutritional doses of vitamin pills. So I was driving through the rain, and my phone rang, and I picked it up, and I was steering around, and it was some woman with a British accent from the Daily Mirror. And of course, their deadline's ahead of ours. And she had seen what the topic of my talk was. And I said, look, I can't really talk now. I'm driving. I'm going to be at the convention center in a few minutes. I'm going to call you back and I'll explain this whole thing to you. She said, fine, that's great. Just one quick question. Now, I shouldn't have answered. I know. Just one quick question and then we'll talk later. I said, okay, fine. What is it? Can vitamin pills cause cancer? I said, yeah, I'll call you back in a few minutes. So I called her back when I got to the parking garage, and she politely said, I don't really need to talk to you anymore because I've already filed my story. So the headline of the Daily Mirror was vitamin pills cause cancer. And so I spent that whole night in my hotel room in Philadelphia doing the breakfast talk shows in London with my computer Skype thing going on. And if you Google me now, you'll see that most of the first few pages on my Google is about vitamin pills and cancer. And it's still fallout from that. I've probably done 50 press interviews. So sometimes prevention doesn't work, and we've got to be aware of it, which gets back to the political point. I not only think, but I am convinced that it's true that there are people getting cancer in the United States today because they take nutritional supplements. And I don't think it's a small number. And so we have to be engaged, I think, in the political realities around nutritional supplements and the safety of what people do in the name of prevention. Finally, is upstream ego. I think prevention's upstream ego. There's a story that many of you heard about either floating bodies or floating babies down the river, people trying to fish them out, and then somebody gets this idea that, oh, why don't I go up the stream and figure out why all these bodies are in the river? Have any of you heard that version? Yeah, and so why don't I go upstream? And the preventionists always tell this story, because why? Well, because the people who he's no longer helping pulling out the bodies are pissed off that he or she is going upstream. And so we in prevention have this sort of puffed up ego about being more virtuous because we're upstream. I've seen it. We don't all have it, but I've seen it. And it's a problem with prevention. Why is it a problem? Because the Affordable Care Act is, if you read through it, and I've read every word, no. but even if you read the highlights, you'll see that prevention is all through it, and improving the health of the population is all through it. Granted, there aren't enough funds, there's not enough incentives, we need to fix it and make it better. But there's enormous opportunities for partnerships, both downstream and upstream, to do prevention. What are the downstream opportunities? Things like hypertension control. My God, it was not the 1980s when we first had a public health approach to hypertension control and awareness. And then as public health, we got out of that business and we gave it over to the clinicians, who have frankly done a pretty good job with it, but there's a whole lot we can do more. A lot of people with hypertension, what, a third, maybe, David, with hypertension have poorly controlled hypertension today. Is it a third, a half?
It's over half.
It's over half. See, it's even worse than I thought. So the Gates Foundation did an assessment of the causes of death in the world. Number one cause of death in the world wasn't tobacco, hypertension. And I did an analysis in Colorado. The number one preventable cause of mortality in Colorado, poor hypertension control. So that's a downstream thing. That's a clinical thing, just as cholesterol control is and diabetes management. So those of us in public health should not feel unclean if we work downstream and work with clinical systems to get done things to prevent disease. And that's the end of my list. When Eisenhower left the presidency, he talked about the military-industrial complex. He did not do anything to actually change it, but he rose awareness of it. So as I'm leaving in my last lecture, before I ask for some questions on my prevention comments, I'm just going to leave you with a thought about departmentalization. I think that's a threat in our profession as we departmentalize ourselves to be clinicians or preventionists and not both. And I think it's a threat in our school as well as we departmentalize our school into professions. We need to be multidisciplinary and multi-departmental to really get things done, I think. So I'm going to stop there and sort of readjust the time, maybe 5 or 10 minutes of questions just on what I said about prevention. This is not a taxonomy of prevention that comes from any theory. These are just random sort of prevention ideas that I wanted to reflect on. This is boiled down from about 15. And if you're curious of what some of the others are, you can talk to me over at the pub later. So I'm going to just stop there and take a breath and ask for questions or comments or feedback about the prevention problems piece of this. I'm patient. And you're not going to hear what I'm going to do next until I get at least 3. Yeah.
So Tim, thank you for all of your insights and other things. I do have a question, but before I ask it, I want to let this audience know that I give you enormous credit, maybe almost all the credit, for deciding we should do a school of public health, departmentalize or otherwise. It was Tim who basically says, well, why don't we just do it? And you can see why he might say that. So, thank you for that. And my question is, why do you think some of these problems exist? I mean, some of them are quite related to each other.
Yeah, so...
or what can we do to help?
I mean, some of these problems are just inherent in prevention itself, like prevention being a shadow and not being absolute. I think some of them might tie. That's a great question. If I could tie them together, I would say
money.
I don't know. No, it's not just money. I don't think it's just. I think money is sort of the result of a value structure. Any other ideas? I rejected money. What?
Departmentalization.
Yeah, maybe departmentalization, maybe siloing, both professionally and not. The National Dialogue on Cancer did some strategic planning a few years ago, and I was pushing this idea that what they should take on is a big idea to create a prevention system. So we all lament that we don't have a healthcare system, but we don't have a prevention system either. We have CDC, we have state health departments, and to some extent they're pretty tied as a system. Then we have local public health. But I'd say a good proportion of the prevention is actually happening in clinical care with hypertension control and hypercholesterolemia, smoking cessation, and things like that, vaccination. But there's no single system that ties that together. And so as a result, we have these sort of floppy, poorly powered surveillance even. Like, what does our hypertension surveillance look like in the United States? Well, we can call people up on the phone at the behavioral risk factor survey and say, do you have hypertension and is it being treated? But we know that half or more than half of them are poorly controlled. Well, why aren't we investing in surveillance that tells us in real time how well our hypertension control is going? Yeah, that's money, but yeah, maybe siloing more than money. Maybe that's fallen between the cracks. And I think there's a huge crack between NIH and CDC. In fact, when I was reading through this thing, I pointed that out, and then both the NIH and the CDC people there said, oh no, there's no crack. Yes, there is. There's no R&D. So we discover things with NIH money that can prevent disease. CDC then goes out and tries to help states to institute prevention, but there's no R&D mentality. There's no way of saying, well, why aren't we constantly improving our tobacco programs? Why aren't we constantly improving our nutritional messaging? Why aren't we constantly improving our trauma prevention programs? Because there's not an R&D mentality. So, yeah, there is some siloing. Other comments? Yeah.
Yeah, I wonder how you would respond to this hypothesis in answering Dick's question that part of the problem is that it's really hard to do public health as a population-level enterprise, and we are very used to doing very individualized care and thinking individualistically as a culture, and that I think that's part of what's holding us back. Would you agree?
Yeah, no, I think you're right, because it's that individual experience that really resonates with us, because we can take the individual experience of ourselves or a loved one who had a disease and it was managed or not by clinical care. But then when we multiply that by 60,000, that multiplication doesn't happen. It's almost like 60,000 becomes less important than one. And so I think there's one of the challenge for us, I think, in the future, and I say us because scientific journalism is one of the things I may get involved in, is how to communicate that, how to translate that, how to make public health improvement or population health, which is sort of the new public health, and from the clinical side, how to make that really work and how to join hands and make that successful. One more, and then I'm going to go on. Yep.
Tim, I just want to turn to your point about prevention being political. across your career, how much progress do you think has been made by the healthcare community in pushing back against the political pressures? I mean, to give an example, the CDC.
Well, I think we've made slow and steady progress. And so I guess I wouldn't want you to take my prevention as political problem as being sort of any kind of an absolute barrier. I think we're just chipping away with it. So, we raised the tobacco tax in Colorado. The Congress didn't want to, or the legislature didn't want to do it. So the citizens did it. And hopefully we'll do it again. I think we keep chipping away on the political thing. So Bloomberg tried to make the big supersized sodas illegal in New York. Well, it didn't work, so it didn't pass the legal issues, so he backed off on it. But supersized sodas now have a different kind of image now as a result. So I think we keep chipping away at policy, keep progressively working on it. So what am I going to do next? So I like carpentry and I like art. I've done carpentry, but I've never done art. And if you wonder what kind of art I'm thinking about, I'll just give you a hint. It involves drips and drops and dabs, and it's sort of aboriginal. And it might get engineered to fuse with macro photography. So see if you can picture that. Creative writing. I want to do some creative writing. I like to write. I may try scientific journalism. I've talked to lots of journalists over the years. I really, really respect those people who can write well for the general public. We as professionals don't really understand what's going on even in the building next door, but there's phenomenal stuff going on. And I think it'd be very interesting to try to describe that and have people understand that. I want to do a lot of hiking. If there's anything on this list that's kind of like a bucket list item, I want to hike every trail in Rocky Mountain National Park. I want to finish that by July. No. A couple years, maybe. I love to fish. I like to golf. You might see me picking up trash on the side of the highway. I think that's probably a good thing to do when you're retired as well. I do want to train for the decathlon. It sounds crazy, but I think I can do that. And I want to learn about both quantum mechanics and astrophysics. Seriously, I do. I'm not going to learn about them mathematically because it's beyond me, but I'm just blown away by the fact that after discovering the Higgs boson, the people running the Hadron Collider in Geneva, the next thing they want to look at, you know what it is? They want to prove that there are small black holes, subatomic black holes. What the hell? I want to learn about that. And I want to learn about why, when you look at the microwave radiation, which is this sort of spherical expanding thing around us, well beyond the furthest galaxies, that is the signal of the first few microseconds of the Big Bang that we can still see and still detect with antennas. And I want to understand why the pattern in it is most consistent with the fact that this expanding universe might be bumping into other similar things out there. So I want to learn about that. There's a lot of interesting things to know. The last thing I want to leave you with is, remember my question for my 4-year-old son? Well, here's my 4-year-old son giving instructions to his 4-year-old son. So family's always been important to me, and I've got 3 kids and 5 grandkids, so family will continue to be important to me in the future as well. I'm going to close there, and there is some time for general discussion on anything that I've said. you'll really do me honor by some comments, by some discussion.
Is this really your last lecture?
Is this really my last lecture? I think it probably is my last lecture on prevention topics, most likely, but you never know. I mean, I may give a lecture on art or decathlon someday, but it's probably my last structured lecture. And people have asked me about sort of my approach to retirement, and I realize that everybody does this differently, and that's great. I mean, some decide they never want to retire, and some just partially retire. Some kind of fully retire, but then they continue to dabble. And the way my mind works, I know that if I continue to dabble, that dabbling piece is going to be too big. And so I'm really using this as an opportunity to really learn some new things. And I gave you a short list of the kinds of things I'm interested in learning now. But I'm looking forward to that, kind of like I was telling Dan, kind of like the kid just before summer break. Is how I feel. So I feel good about my career. I am very positive about prevention. I think we're making enormous progress as we're aware of these problems and address them and deal with them. I think we'll make even more progress. So, yeah, this is probably my last lecture of this type. Yep.
A comment and a question. Comment is I'm very jealous hearing your retirement plans. They sound really good. And the question is, if you could wave a magic wand, what are maybe 2 or 3 things that you really would like to see the Colorado School of Public Health accomplish, say, in the next 3 years?
So the question is, if I could wave a magic wand, what are the kinds of things I'd like to see the Colorado School of Public Health do in the next 3 years? I would say figure out a way to, and I'm not going to harp on departmentalization because I think I made that point, but figure out a way as a school to get effectively engaged with population health improvement hand in hand with healthcare systems around the state. I think there's an enormous opportunity there. And really make this distinction between public health and population health, public health and clinical care, really blur that distinction. So if I could wave a wand, I'd say it'd be something in that realm.
If you had to go back and give your 35-year-old self advice over the last 30 years, what would you say?
So if I had to go back and give my 35-year-old self advice, what would I say? I really don't know. I mean, I don't think I would have pointed to any a different path. I mean, my philosophy is that there are some wrong paths in retrospect, but I don't feel like that's happened to me. And usually you just kind of keep going forward on the choice that you've made. So I think patience would be one thing. Sometimes I get impatient. And so that can be both a virtue and not. So I think always being able to step back and be patient and say, yeah, things don't look really great here right now, or this month, or maybe this last year. But you know, there's ways we're making it better. There's things we can do that are better. So patience is important. Yep.
So probably not a lot of people in this room realize that you spent the last couple of years dabbling in
marijuana. Is that what you're going to say?
Almost. Dabbling in the potential benefits of medicinal uses of marijuana. So having said what you said about the definition of epidemiology, we'd like to impart some wisdom about how medicinal marijuana may prevent people from getting broken down by age and sex.
Yeah, medicinal marijuana. I mean, there's another example of where I think here in Colorado we're doing a pretty good job of sort of merging public health and clinical aspects of marijuana. Obviously, we could do better in both, but I think we're doing a pretty good job of keeping our eye on what the right problems are in that area. And I am hopeful that, you know, whether it's marijuana or any other kind of remedy that people choose, and I'm always careful when I talk to the general public not to step too hard on choices people make. It's hard sometimes, especially in nutritional supplements where there's harm that's being done. But I'm always careful because I know that when people make their own choice for health, that's a powerful thing. Just that choice itself is a powerful thing. It's part of the placebo effect and everything else. But yeah, I hope we figure out more about both medical marijuana and other aspects of other choices people make. One or two more comments, and then I think there's a pub thing waiting. Yes?
Hello, I'm Isabella Malika, and I am a junior in high school. My mom speaks very kindly of you. Anyway, so my...
And who is your mom, Mike?
Angela Sawai.
Yes, Angela.
Dr. Sawai, I'm sure you all know her. Anyway, I have two questions. So my first question is, you described the lower death rates in cancer-related deaths by about 26%.
26% in the last 25 years.
Can you attribute most of that success to preventative medicine?
Yes. So most of that success comes from tobacco control. Somewhat less, but not substantially less, proportion of it is from improved treatment. So we've come a long way in the last 25 years in improving treatment for cancer and in preventing it. And some of it comes from colonoscopies, and some of it comes from a few other things. But I think the declining death rate in both heart disease and cancer is a testament to the fact that prevention and treatment both work, and they work well synergistically. When I was writing this paper on this 25-year reflection of what's happened over the past 25 years for cancer death rates, I was just about done with it when I was watching the State of the Union address, and President Obama turned to Joe Biden, and he said, "I'm going to put you in charge of the moonshot." I go, "Oh shit, I got to rewrite my whole discussion." So I did. So I talked about moon shooting, and what I said there was a big lesson from the past 25 years is that curing cancer isn't just a therapeutic challenge. It's a prevention challenge as well. We can cure the cancer problem by prevention, and we can cure it by treatment. You said you had two questions.
Yeah,
that was
one
the
more
first.
question. So I just got out of the eating disorder unit here at Children's, and I was curious if you know anything about prevention of mental illness.
Prevention of medical illness.
Mental illness.
Oh, okay. So the question is, what do I know about the prevention of mental illness?
Yeah.
That's a good question. The prevention of mental illness, I would say I know very little about it, but I think that the prevention of mental illness is going to involve group psychology and sociology and spiritual issues that we don't often feel comfortable talking about. The prevention. Now some mental illness is just biochemical wiring gone wrong. Much of it is, and so there it's about first of all understanding what causes it and how we might prevent it from causing it. And we're not very close to understanding what causes it. Other aspects are then early diagnosis, so people can be more aware. Oh, you have this as a risk factor. Let's deal with it as a family. Deal with it as a group. But Dave, I'd be interested in your thoughts. Our pastor who's here about the spiritual aspects. I mean, I think in science and in public health, when we talk about things like mental health and free choice and behavior and happiness as outcomes, we don't talk about the spiritual realities that we know are there because we're in some government agency or we're somehow afraid that people are going to misinterpret what we mean when we talk about spiritual. They think we're going to be some evangelical thing that's going to be the next thing coming out. But would you agree that we need to figure out how to integrate spiritual and psychological and physical health better?
And the pushback these days is not just from academia. For those of us who are in this realm, we're seeing a profound distaste for speaking about spiritual matters. But just as in emotional health, it affects many other aspects of our well-being.
Yeah. So if we don't really know, like, who am I, or who am I growing up to be, or why am I different now than I was, last year, or why am I here? What is here? What's the purpose of life? I mean, those are questions that can make you kind of wobbly. And I think those are spiritual questions that we all deal with. Last question.
Can you identify one thing you've done in your professional career that's been the most gratifying?
So the question is, can I identify one thing in my professional career that's been the most satisfying? No, and it's not that I haven't thought about it. In fact, my grandson Charlie, recently, when I was retiring, I was driving him somewhere in the car, and he said, "Grandpa, what did you discover?" Good question. I mean, I knew going into research that the likelihood that I would discover that sort of Byers principle, I knew that was a low probability because there aren't so many of those. And I said, well, I think my answer to him is probably as good as to you, and that is that it wasn't that I really discovered any one thing, but I did help. I helped move a lot of different things. I help by being part of groups in discovering some things and sort of pushing some boundaries and doing some new things that I won't say wouldn't have happened otherwise, but I know they wouldn't have happened in that time frame, like Wise Woman, for instance. Probably would have happened eventually, but it happened sooner and quicker because I happened to be there at the right time. Thank you all for coming. I really